So we go to the next presentation, which is History of Sleep Disorders in Kidney Disease by Rosa De Santo, Biagio, Raffaele, Iorio, Natale Gaspare De Santo. Please, the speaker for presentation.
Professor Racchi, Professor Biagio, distinguished survivors of a very successful medium. The senior author of this paper has already regretted with the President of the Congress about their impossibility to be with us. Being here in Turkey, we cannot speak of sleep without mentioning the cave described in Surah 18 of the Quran. And there are refugees in the cave. They didn't realize how much they had slept, and in fact they thought that they had slept just one afternoon, but of course God knew better how much they had been sleeping. Speaking of sleep, we have to go back to classical Greece. I will take from this first list the fact that sleep in Greece was located in the Isles of Lemnos, where even Juno flew to visit the brother of that to induce sleep in Zeus, and this spirit in Iliad's book. Hesiod wrote that Nyx bore beautiful Moros, dawn, and the black cat, the destiny, and Thanatos, death. She also bore Hypnos and the tribe of the Honorable. It is the theory of Hesiod. I just want to mention Epimenides. It is written that he lived 150 years, but that he slept 6 years or more. Euclides of Megara identified the sleep as a giant devil. Diogenes of Apollonia just utilizing the best of his knowledge, medical knowledge, and thought that sleep is caused by mostly of eye and the sound. And more or less is the problem of Empedocles, for whom sleep depends on a moderate cooling of the warmth of the blood. Empedocles is a strong scientist. In another occasion I went on Empedocles to the table of the elements, but he pointed out that it depends on the separation of element fire. For Aristotle, sleep is a deprivation of cooking, and in the Somno et Vigilia, he says that there is no perception. I would like to start with the down statue of the Immobile that is in the Cogeum of Valsalieni in Malta, and also now to go to the left, that is more or less a sketch of the other. Sleep indeed is a recurrent dynamic process that affects every body function for nearly 1/3 of the day and has a housekeeping role. It regulates metabolism, immunological function, poor sleep with short sleep duration may cause obesity, diabetes mellitus, high blood pressure, heart attack, stroke, as well as attention, loss of attention and memory. Now we know that sleepless 5 hours per night is associated with a 30% reduction of estimated glomerular filtration rate and incident of CKD. Everything started in the laboratory of Charles Mignon, Montpellier. The first paper on the disturbance of sleep disorders in dialyzed patients was not in a nephrological journal. You see that it was published in a journal of encephalography. And Charles Mignon and his collaborators pointed out that there was a big loss of synchrony in the sleep. The structure was completely lost in all phases of sleep. Now let's go to those who have started the refilled. They were all paper. The tara list here you see are not written in nephrological journal. They are all written in general journal, British Medical Journal, and let's say that Lancet and so on. A big man of this time was Norman B. Levy, who really did a lot in New York working with Eli Friedman. And he came frequently in Europe at the time when nephrologists, Professor Janusz Ostrowski says that it is before nephrology before nephrology. And he counseled a lot on this and visited Europe frequently. And the many conferences that which were published in books that the new generation have never opened. However, if we look now to sleep disorders in CKD, dialysis and transplantation, I go to this with a recent paper. It is a systematic review and a meta-analysis on nearly 4,000 articles between 1990 to 2010. It is around 46,000 patients on CKD or on peritoneal dialysis or on transplantation. A total of 90 articles were selected. The conclusion that the prevalence of poor sleep was nearly 6% in CKD, 68% in hemodialysis, 67% in peritoneal dialysis, and was very high in transplantation. The corresponding prevalence of insomnia was around 50%, and just in 26% of transplanted patients. This is a prevalence that is in a heterogeneous population, but I want to show you that when we do this global systematic review, we mix many things together. Have a look to the yellow circles. They do not represent the world. They represent just small parts of the world where medicine is practiced in the best way. So, going back to the insomnia and poor sleep in CKD of Dan and his collaborators, we see that poor sleep and insomnia are characterize patients with the disease. Sleep disorders, I don't have time to discuss things, but are insomnia, sleep apnea, restless sleep syndrome, periodic limb movements. There are the consequences for this, that is fatigue, excessive daytime sleepiness, impaired daytime function, impaired health-related quality of life, increased morbidity and increased mortality. However, we have learned that sleep quality predicts the quality of life, but also the mortality in hemodialysis patients. This is the top study, and you see the risk going from poor sleep to optimal sleep, that there is a 30% difference in death rates. It was very simple at the very beginning. We discussed such things in a very simple way. We linked it to the losses and the dependencies of a life-dependent machine. When you are a parent and you don't lose only urinary function, you lose your social role, you lose the family dynamics, you lose the role in the family, and you lose many other things that make life pleasant. And you depend on the dialysis staff, on the physician, and so on. We have tried to assemble together the philosophies in this screen for this Congress. In another part, we could not have such a table, and I really appreciate that we can show such a table. There are demographic factors, lifestyle factors, disease-related factors, there are social factors, there are psychological factors, and there are treatment-related factors. Indeed, there are sleep disturbances and there are severe dialysis patients. We have already seen insomnia, sleep syndrome, restless leg syndrome, and we have already described the effects in the previous slides. However, if we look to the history of the patients with sleep disorders, even going to the best of the escritor, you see that today GFR was around 21 milliliter per minute, but at the date that it is nearly dialysis, and is 53% of the poor sleepers. But if you go below the grade 3 of residual kidney function, the number of poor sleepers is also reduced. In our laboratory, we did something very different. We published 3 articles around before in 2006 and 2008. We started the sleep disorders at the time of the CKD diagnosis because there was the psychologist working with us, and we physicians think always that the psychologist is another thing and the complicated things. So, looking at the patients at the time you diagnosed them, they were 124, they were studied with another group of patients with chronic liver disease. So, the methodology was that way. Their GFR was around 60 ml per minute. They 85% of them were on an hypotensive. None of them received the erythropoietin. Of 124 patients, there were 90% of poor sleepers. Of course, they measured at that time the Charles comorbidity index, and the interesting thing is that there was no correlation with the Charles comorbidity index. So there is a role for the psychologist to participate, since it's the introduction of a CKD that triggers the event for poor sleep. The perception of loss or future losses of functioning independently of renal function. That is insufficient elaboration of coping with a chronic disease, usually viewed as an association that includes lifelong constraints. So we go back to the great studies of narratives of adherence that indicated that the discovery of having a renal disease is a life-disrupting event, so patients need to create meaning and establish situation in their life. Discovering to be affected by a chronic process with an unpredictable time course with many potential comorbidities is a deconstructing event. So the time of diagnosis is crucial. The patient is forced to admit that his body is ill. It can't be restored to complete ill health, and in the future will be associated with the loss of autonomy. We have learned that the worst sleepers were modernized patients requiring parathyroidectomy. This study is quoted several times, and is done in a group of patients needing parathyroidectomy and confronted with a group of patients not needing parathyroidectomy. And you see that the PTH was around 1,400 in patients needing parathyroidectomy, and more or less about 400 in those not needing parathyroidectomy. If we look, let's apart from the left, that there is a lot to discuss for a nephrologist, and we go to the right see that those needing parathyroidectomies led more or less 5 hours. They had less daily naps. The patient without sleep disturbances were a minority, 5%. So more or less 70% of the patients had sleep disorder. I want now to move to something which originated really in our laboratory. Alexithymia is a personality trait that reflects difficulties in affective self-regulation that was introduced in medical literature by Peter A. Sifnios in 1997. In immobilizing the patient, the studies have benefited by the many contributions of Fukunish et al. Starting from 1989. As reported in 2010, alexithymia incorporates difficulties in distinguishing between feelings and the physical sensation of emotional arousal, limited marginal process, and an externally oriented cognitive style. It has been associated with physical and mental health problems, substance abuse disorders, and the mortality in general in the population. The prevalence is 4 to 13% and is considered a potential way of dealing with a disease generated stress. Let's go back to the patients needing a parathyroidectomy. The so-called Toronto scale was positive in 80% of the patients. So what is important that the patient not needing a parathyroidectomy, they had less prevalence of alexithymia, and the statistical of this paper are crucial, and this a paper that was built with a progression. I think that there were also patients of Vincenzo Savica in this study. So if we go before a parathyroidectomy, people had alexithymia 80%. They were operated 3 years after the parathyroidectomy. When PTH was only 45, you see that they still have 50% of alexithymia, but the reduction was significant. I am going to conclude. Chronic kidney disease includes sodium and water retention, including fluid overload. We have seen that even the box had overload by kidney disease. There is rostral fluid movement, there is pharyngeal edema, there is lung enlargement, there is airway obstruction, and this is a cause of obstructive sleep apnea. But the chronic kidney disease has metabolic acidosis, hyperventilation with hypocapnia, there is enhancement of the chemoreflex sensitivity, there is reduction of PCO2 below the 90 threshold. All this goes to obstructive sleep apnea. However, obstructive sleep apnea induces nocturnal hypoxia, induces renal tissue hypoxia, and also does something that yesterday morning Professor Ekroyan explained that it is difficult to tell what is interstitial and what is glomerular, as Guido Gentile remembered speaking about his talk about the 150th anniversary of Fonardenthal. But the problem is that there is increasing sympathetic tone, as Professor Biagio demonstrated just a few moments ago. There is RAS activation, there is hyperfiltration, there is chronic kidney disease, but there is also hypertension, and this makes optosis damage, tubular interstitial injury that leads to chronic kidney disease. Nocturnal hypoxia causes inflammation and causes oxidative stress. increases the asthma, and there is nitric oxide synthesis, and there is low nitric oxide availability. All things go to chronic kidney disease. Recently, we have learned that people with nocturnal hypoxemia have no memory, as you know, declining GFR. But many have a mild decline in GFR, let's say it's around 5 milliliter per minute per year, and many others have moderate to severe loss of glomerular filtration rate. So now I want to complicate things and have a look to another way. The Journal of Political Philosophy wrote a great pamphlet about the contemporary, the Italian justice, that is the contemporary changes in sleep practice centered on a three standard tendencies. There is the shortening of sleep, there is the regularity of sleep, there is the synchronization. I don't have the time to play with such things which are important. They are a problem with justice insofar they are argued to some undeserved and are available. So there is now time for the last slide, that is from Turandot. Nessun dorme tu cubre principessa. This is words of power. Thank you.
Thank you, Professor, for a very nice and interesting presentations. Is there any question from the audience? Comments? I have actually a comment very shortly. So, if the prevalence of insomnia is so high and CKD, this might be another possible symptom that we might search in historical figures to understand if they had some problem in the kidneys.
People who are aware of the work we do now are aware of this. How this is associated with other things we study, with another methodology, the documents we do, but they have an interference and correlate with sleep disorders.
Yes, for example, in the popes, it could be interesting to know the prevalence of sleepiness in popes' history and to see the correlation with other symptoms.
Thank you for commenting with Professor Biagio.